So hi everyone, my name is Julia Mayetta. I'm so pleased that you all could join us today for this week's lecture in Volume 3 of our 12-week No Neuropsychology Didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists to provide free high-quality didactic opportunities, and we would like to thank our sponsors for their financial support of this series. Before we start, here are the disclaimers. This training is not meant to replace formal education in neuropsychology, and the views of this questions for the speaker today can be submitted via the Q&A box, which is on the lower left or middle of your screen, and we will post a recording of today's lecture on our website later this week. Now it is my pleasure to introduce Dr. Sarah Weisenbach for today's lecture on the neuropsychology of depression. Dr. Weisenbach is an associate professor in the Department of Psychiatry and Behavioral Health at Stony Brook University. She is a board-certified clinical neuropsychologist studying the mechanisms and deficits underlying depression during middle age and late life in a developmental and longitudinal context. She translates this knowledge into effective neuropsychological and neuroimaging tools to monitor the course of illness and cognitive decline and conversion to dementia. She completed a Career Development Award through the VA Rehabilitation Research and Development Program that investigated reward, memory, and executive functioning brain networks in older adults with depression and how patterns in these networks predict cognitive decline. Her R01 award investigates how sex and depression severity moderate emotion regulation skills in middle-aged and older adults and the role of executive functions in emotion regulation using multimodal measurement strategies. Dr. Weisenbach is also funded with an NAR-SAD Young Investigator Award through the Brain and Behavior Research Foundation for a project of epigenetic mechanisms of late life depression and cognitive decline. Dr. Weisenbach earned her PhD in counseling psychology from Colorado State University in 2005, and she completed postdoctoral fellowships in clinical and research neuropsychology and advanced geriatrics at the University of Michigan and VA Ann Arbor Healthcare System, respectively. She began her position at Stony Brook in August of 2019, following her position as an assistant professor of psychiatry at the University of Utah. So we're certainly very pleased to have Dr. Weisenbach here today to talk with us, and I will turn it over to her.
Thank you so much, Julia, and thank you to Dr. Sperling and the other members of the organizing committee for this invitation today. It's lovely to be here. I am going to go ahead and share my slides. Give me just a moment. Oh, let's see. You probably can't see that, can you, or can you?
I can see part of the screen.
Oh, I see what the problem is. Okay. This is interesting. How's that?
That looks great.
Okay, perfect. So today I'm going to be talking about the neuropsychology of depression across the lifespan. So I'm going to start with just talking about the public health impact of depression, and then we'll describe the multiple facets of depression, depict how genes in the environment interact in depression, most importantly for this seminar, probably outline how cognition is impacted in depression and discuss theories underlying cognitive dysfunction in depression, and then talk about some of the brain structures and brain circuitry that are most relevant to depression. And finally, at the end, discuss the current state of applied neuroscience in depression research. So 20% of Americans experience a mood disorder at some time during their lives, with yearly prevalence rates of 10%, and with a prevalence rate specifically for major depressive disorder of 6.7%. As many of you know from intro psychology courses, women are twice as likely to experience depression than are men. In terms of the age range, it turns out that before adolescence, boys and girls are at about equal likelihood of experiencing depression. But after adolescence hits, girls and women are twice as likely to experience depression than are men. Later in life, we see higher rates of not necessarily major depression, but of all comers depression that can cause functional decline as well, or functional disabilities as well. So while rates of major depressive disorder are lower in older adults, when we look at depressive disorder, NOS, for example, or other types of less severe mood disorders than major depressive disorder, we see higher rates than we do in younger people. Depression is the leading cause of disability worldwide, and an estimated cost of 210.5 billion US dollars per year. Just try to wrap your head around that for a minute. $210.5 billion per year in the US alone. So our first key point, or take-home point, is that depression is relatively common. It's experienced by about a fifth of Americans at some point during their lives, and it's the leading cause of disability, and it is expensive. So I like to, in the field actually, tends to think about depression as representing four different pillars. So the first are probably the area that we as neuropsychologists are most concerned with. So difficulty concentrating and making decisions, recurrent thoughts of death, suicidal ideation, plan or attempt, and slowed processing speed. There are also, of course, emotional aspects of depression, including depressed mood, irritability, feelings of worthlessness. The motivational aspects of depression include apathy and anhedonia, psychomotor retardation or agitation. And then physiological components of depression include appetite and or sleep changes, fatigue, and loss of energy. Given that my field that my particular area of interest is in middle-aged and older adults, I'll just say a little bit about some of these symptoms in older people and how they differ from those in younger people to some extent. So I think it was George Alexopoulos that termed the phrase depression without sadness in older adults, or at least he referenced that in one of his publications. And that's a very good description for depression in many older people that you might see in clinics. So if you ask many older people who are depressed whether they feel sad much of the time, they may say no. But then if you ask about dropping activities or how they spend their time each day, you may get an answer like, well, I watch TV. I don't really feel like doing a lot. I'm just not very motivated. So we tend to see a lot more apathy in late life depression than we do in earlier life depression. And then we also tend to see a lot of physiological symptoms. So it's tricky though in older adults because many of them also have other medical comorbidities that could account for some of the physiological changes. So assessing depression in older people, while the criteria are the same for diagnosis as in younger adults, it's important to pay attention to the way that questions are being asked in terms of, the core features of depressed mood or anhedonia, especially. So there are actually 227 ways that someone can meet criteria for major depressive disorder according to the DSM-4 or DSM-5. So a combination of 227 different combination of symptoms can actually lead to a diagnosis of major depressive disorder. And I show this slide because depression, as I indicated before, I talked about 4 pillars, but we might divide it up even further if we think about the research domain criteria that NIMH created. It's been a while now, I think it's 8 or 9 years ago now, maybe more, that was an attempt to study the etiology of different mental health issues as opposed to just the categorization of them by symptoms. So, for example, active threat or fear, we often associate that with anxiety disorders, but that can also occur in other kinds of disorders as well, including psychotic disorders. Positive valence, a reward, we see that as a primary issue in depression many times, but we can also see that as an issue in schizophrenia, for example, with some of the negative symptoms. And then other domains, including social, cognitive, and arousal and regulatory, those also overlap among different mental health diagnoses. And so the RDoC criteria were an attempt to stop basing our treatments and our understanding of mental health conditions based on just the description of symptoms that tend to run together, and instead explore some of the underlying etiology that can cut across multiple mental health diagnoses, and that if we understand some of these different domains and how they function in people, then we may be able to come up with more personalized medicine to treat individuals with a variety of mental health conditions. So this is, again, this relates to depression though, and that you may have someone come in who has significant reward related difficulties, such as the person with apathy that I described before. But it turns out maybe that their memory is quite good, but they have some maybe executive dysfunction that relates to difficulty of regulating emotions, and also maybe some social disconnectedness, where you can see a totally different profile in someone else with major depressive disorder. So just kind of a reminder that I know that we're all trained to rely on the DSM-5 as kind of our Bible for diagnosis, but just to remember that many of these disorders share common symptoms, and oftentimes the treatments that are catered to an array of symptoms for a given individual may work across multiple kinds of issues that people come in with. So again, depression can be characterized by a combination of cognitive, motivational, emotional, and physiological symptoms. And importantly, of course, in DSM, you see this with pretty much every disorder, that are of significant duration and severity. So we all have heard of the biopsychosocial model, and so I want to talk about it a little bit more in detail as it refers to depression. So we know that risk-conferring behaviors, as well as genetic susceptibility and environmental factors, often combine to kind of create the perfect storm for someone to enter a first episode of a mental health challenge. This is a model that is based on some of Kendler's work back in the 90s, and then into the 2000s, where it's a lifespan model of depression that depicts the interaction between biological vulnerabilities and environmental factors for psychiatric illness. So depression is fairly uncommon in early childhood, but rates increase as people reach adolescence and early adulthood. And it turns out that as people get older, depression length often increases, and the time between episodes, as you can see by the black here, also tends to decrease. We know that if we treat depression early and effectively, then people are less likely to develop a second or subsequent episode of depression in the future. So there's a lot of work going on focusing on this group right here to try to prevent first onset of depression in people who are at risk of depression, such as by virtue of their genetics or their family history, to prevent these longer and more severe episodes that we tend to see a little bit later in life. And we can think about also life events and stressors that can vary in intensity and duration. So it's probably no coincidence that when we see this increase in depression, especially in women and girls around this mid stage of adolescence, There's also a lot of other stressors that are taking place regarding, identity and um, academic stress and maybe family stress that's going on at home. And so those interact with probably the neuroendocrine system in conferring a greater risk of depression for women and girls at this stage. Not that boys don't also experience those stressors, but their neuroendocrine profile is quite different. And then into adulthood here in sort of middle age, this is where we see people starting to retire, another major life transition. And we also can see new onset of depression in late life, especially among people that have cardiovascular issues like diabetes, high cholesterol. And of course, there are also genetic vulnerabilities to those diseases as well. And then we know that treatments can mitigate the effects of stress, life events, and depressive episodes themselves. And these treatments can also vary in intensity and duration depending upon the severity of the episode and kind of where someone is in their developmental trajectory. I'm going to skip a few slides just to move ahead here because I know I tend to get behind really easily. So this is probably the most famous study looking at the interaction of genes and life events. This was a study done by Caspi back in 2003. And these are 3 different types of 5-HTT-LPR alleles. So long, 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 and short, short. And what this graph depicts is that these are self-reported symptoms of depression on the left. So folks with the short, short allele combination had the highest rates of, everyone's number of stressful events increased over time. However, those with one stressful event didn't really differ in terms of their depression symptom severity. But as stressful events became larger, 4 or more, those with the SS allele had higher symptoms of depression than those with the short long allele or the long long allele. I won't go through the other graphs because it's sort of a similar explanation. You can see that those with the SS allele, no matter what you're looking at, probability of suicide or attempts, probability of major depression, and informant reports of depression, it's all a similar story where those with the SS allele had the most risk of developing these different outcomes as the number of stressful life events increases. So depression results from a combination of environmental, genetic, and behavioral factors, which I know is not alarming news to anyone on this webinar. And so probably the part that everyone is here on this talk might be most interested in is looking at how cognition is impacted in depression and why we tend to observe cognitive dysfunction in depression. So it turns out that many different domains of cognitive functioning are affected in depression, even in younger people with depression. We see greater impact, we see greater severity in performance in these domains in older adults and even late middle-aged adults, but we do tend to see differences also even in younger people with depression. And the more episodes that someone has of depression, the more likely we are to see decrements in these different domains. So attention and executive functioning, processing speed, fine motor function and speed, emotion perception, which we often don't do a great job of assessing in neuropsychological contexts, reward anticipation and pursuit, and memory. So a number of different domains. What about domains, though, that are unaffected in depression? So these would include language, visual spatial skills, academic skills, effort, which we'll come back to in a few minutes. This has been a hotly debated issue in the field of neuropsychology. I think you hear less often, but still hear beliefs that the only reason that we're seeing cognitive decrements in people with depression is because they're not able to put forth enough effort. but I'm gonna try to dispute that with some data, and then also with what we know about the neuroscience of depression and how that most certainly relates to some of the neurocognitive outcomes. And then also crystallized intelligence doesn't tend to be affected. So this was a study by Snyder in 2013. It was actually a meta-analysis of many studies looking at different domains of cognition among people with and without depression. And so 0 is sort of the what you can think of as the healthy controls, never depressed controls being here. And then what is the effect size for people with depression? By and large, you see the largest effect sizes with verbal working memory, and this was just the digit symbol test, but we can think of this, it's a complex measure, but we often use it to measure processing speed. And then, but we also see not sort of moderate or, well, small effect sizes. Anything 0.5 and above is considered large. So we see large effects in verbal working memory and processing speed. We see smaller effects in inhibition, shifting. So we can think of those as executive functioning. I'm sorry, you know what? This is actually, I got confused with the wording. So this large effect is actually updating. So an aspect of executive functioning. So executive functioning overall has some of the largest effect sizes. But we also see effect sizes with regard to working memory, which you can argue is related to executive functioning, as well as planning, another aspect of executive functioning, verbal fluency, another aspect of executive functioning. But when you look at just vocabulary knowledge, really not an effect size. It's minimal, not significant, or not significant, but it's minimal, not really anything to write home about. So let's look at some of these domains more specifically. So this was a study of psychomotor functioning in chronic fatigue syndrome and major depressive disorder. And what the person had to do was they had to copy simple lines quickly or copy more complex figures quickly. And it turns out that people with depression perform more poorly than both people with chronic fatigue and healthy controls than did, so they perform more poorly than both of those other groups. So this could, if we get back to the effort hypothesis, this isn't necessarily a study that was related to the effort hypothesis, but you would think that if effort was an issue, we might see similar performance in people with chronic fatigue syndrome and depression, because you would also think that, people with chronic fatigue may also not be able to expend as much effort. But it turns out that people with depression actually performed even more poorly than people with chronic fatigue syndrome. I'm sorry, so the difference was actually in the lines, but not in the figures. But when we look at the MDD compared to the controls, there was poor performance in both of these domains. So how about emotion perception? This is something that we don't do a great job of measuring in our typical neuropsychological evaluations, probably because the purpose of our evaluations oftentimes in depression is for a pre or post ECT evaluation. That's a common one. Or someone that is in school or in a job and they're struggling, and the referring provider hopes to understand what the specific issues are that can perhaps be compensated for while the person is undergoing this active episode of depression. But what we showed in this study is that so women with depression had more difficulty classifying fear and anger relative to women without a history of depression. But we didn't see that difference in males with depression. They performed equivalently to their similarly aged peers. And so there was a gender by depression interaction here where we saw, at least in these younger, this was a younger sample. So we saw an interaction here between sex and depression. And it's interesting that women had a harder time classifying fear and anger. You would think, but not happy. So there's something about fear and anger. I'm sorry, fear and sadness that is relevant to depression. And you might think about fear as being, it's a threat emotion. And so if I classify a neutral face as fearful, I'm more likely to protect myself than I am, it doesn't matter so much if I misclassify a neutral face as happy. And then I'm not showing the data here, but we also had a study where we looked at emotion perception using a similar face emotion processing task in older people with depression. And we compared those to younger people with and without depression. And it turns out that later in life, that gender difference that we see in earlier in life with depression, we don't see that anymore in later life. So women and men with depression had a more difficult time with this task than did their similarly aged peers who were never depressed. So anhedonia, or the decreased capacity to enjoy or experience pleasurable activities, is one of the main primary criteria for a diagnosis of depression. So either depressed mood and or loss of interest or pleasure. So this was a reward learning task whereby the person was asked to classify a line as that was supposed to be a mouth as either long or short. And one of these was rewarded more frequently than the other. And so controls actually tended to have these are, in truth, these lines are exactly the same length. But controls actually tended to have, they learned over time that, one or the other, the long or the short, was rewarded more frequently. So they started to display a response bias toward that which was rewarded more frequently. Whereas those with a depression diagnosis did not experience that learning, and in fact, actually tended to display really no response bias at all by the end of the task. And so, so there's this reduced reward learning that that actually ends up predicting outcome in major depression. So in this study, those who had reduced reward learning at baseline were less likely to respond to, I think it was an SSRI medication over 12 weeks, I believe. This is really interesting because I think we often think of memory disturbances as primarily happening in older people with depression, and perhaps they're also undergoing a neurodegenerative condition. But this was a study, an older study by Grant and colleagues, that showed that even in younger people with depression, we see difficulties with learning and memory. So you can see significance for both immediate and delayed recall on visual reproduction and on immediate and delayed recall for the HVLT. Now, these are not huge effects if you look at the raw scores, but still you can see the difference there. And so even early on in life, we do see these memory decrements, let's call them, not impairments, in young people with depression. So I mentioned earlier that there's been a lot of contention about the effort hypothesis in depression because sometimes you see erratic performance, so where there's inconsistency in the performance of similar tests. And then there was this effortful automatic hypothesis that was proposed by a number of researchers in the 80s and 90s that posited that those with depression have difficulty effectively allocating effort when challenged by a more demanding cognitive tasks. So some of the evidence that was presented for this was that executive functioning tasks are challenging. Perhaps that's why we see the biggest effect size in executive functioning tasks in depression, because they do tend to be among the most challenging tasks in our battery. And then in memory tasks, recall is often worse than recognition. So, and again, a harder task is often worse than this easier recognition task. This was a study, and this debate is still taking place in the field. So it's still being argued to this day. But we have done formal effort testing among all of our samples with depression in an effort to demonstrate that despite good effort, at least as we would define it in neuropsychological terms using standardized measures, we still see significant decrements in multiple domains. So here we used the CVLT, and we also used the TOM, the test of memory malingering, which many of you are familiar with. It just includes presentation of visual stimuli and then a yes/no as to whether that visual stimulus was presented. And so here you can see that, and these are just the Z scores, the normative scores on the CVLT. You can see that those with depression perform significantly more poorly across every single trial relative to controls, even in easier trials, the recognition trials. However, performance on the test of memory malingering for every single one of these individuals was well within normal limits and often perfect. And so that was one piece of evidence that we were able to write up, suggesting that it's probably beyond just not able to give enough effort that we're seeing decrements in different cognitive domains. I want to mention this study because this is a study specifically of older people with active and remitted depression. And it's a large study of 438 older adults. This was done out of University of Pittsburgh by Merrill Butter's group. And this study recruited people with active depression, people who had remitted from depression, and then never depressed controls. What you see here is that those with active and remitted depression tend to perform more poorly than controls, but not typically significantly different from each other across multiple cognitive domains. And here, even with regard to visual spatial ability, which is not usually what we see in younger people. What's most disturbing about this study to me is that remission of depression, what this means if we're seeing equivalence in performance or non-significant difference in performance among controls and people with people with remitted depression and active depression, is that just because someone recovers from a depressive episode later in life does not mean that we will see cognition return to baseline. And I think this is really clinically relevant because a lot of us see patients who are referred for an evaluation of depression versus dementia. And oftentimes the hypothesis is that if we do see some decrements that don't necessarily indicate dementia at this time, often the hypothesis is, well, once the depression is remitted, the person will be functioning cognitively normally. And these data suggest that that is not necessarily true, that the person may not be likely to return to baseline. And it's also likely that some of the people in this study were in the process of a neurodegenerative condition that wasn't revealed yet at this stage when they came in for evaluation. So I think it's really important to communicate in our summary and our recommendations to clinicians that this person won't necessarily return to baseline with, effective treatment of their depression in regard to cognition. So, and that's kind of a change from when I went through my postdoc training. We would often say, with proper treatment of depression, we would expect cognition to return to baseline. And these data and other data suggest that that's just not true. Um, I mentioned that we talked about one theory of cognitive dysfunction in depression being the automatic effortful hypothesis. But there are a number of other hypotheses that I wanted to mention. So one is the frontal lobe dysfunction hypothesis, which really comes from lesion studies where people who had a lesion in the right frontal region tended to experience emotion dysregulation and lability, and in the right posterior regions tended to experience kind of apathy, poor perception, kind of a blandness. And so together, this kind of this theory posited that frontal lobe and its disconnections may be relevant for cognitive symptoms in depression. And then here in the left frontal regions, we see this sparsity of positive affect. And so together, especially the frontal findings, the theory was that damage to prefrontal circuitry might confer risk for depression. And we actually know that to some extent is quite true in the late life literature, particularly where we see older people with cerebrovascular disease that is in fronto-subcortical networks. And sometimes we see first onset of depression that kind of tracks along with the development of that cerebrovascular disease. And so to some extent, there is support for this hypothesis, particularly in older adults. There's also the motor speed hypothesis, which posits that motor slowing that we observe, even for simple motor and copy tasks, like the one I showed you earlier, might explain some of the cognitive deficits that we see in other areas where psychomotor speed is required for successful completion of the task. That doesn't explain, though, performance on tasks that don't require psychomotor functioning, such as verbal learning tasks, for example. And then another theory is the hippocampal dysfunction hypothesis, which is supported by studies of the hippocampal volume in people with depression, some but not all of which show hippocampal atrophy in depression, or if we don't have longitudinal data, just a smaller hippocampus in people with depression. And that people with depression, a number of them do not respond to a dexamethasone suppression test, which is a cortisol functioning test or an HPA axis test. And then there's also a strong animal literature supporting this hippocampal dysfunction hypothesis, whereby if a lesion is made in some part of the hippocampus, then we might see sort of depressive-like behaviors in rats, for example. And then also, a lot of people that we see in clinic with depression tend to complain of memory difficulties. So there is support for this hippocampal dysfunction hypothesis, but it doesn't really explain all of the neurocognitive effects that we see in depression. And not everyone with depression who has cognitive difficulties has hippocampal atrophy or HPA axis dysfunction. So I want to turn to a more recent theory that has been posited by my former mentor, Dr. Scott Langenecker, and others, which posits that depression is a disease that results in both difficulty controlling one's thoughts and emotions. So we have to bring emotions now back into our sort of way of thinking about cognition in depression. So this is kind of a complicated slide, but we have the salience and valence circuit, which just really is kind of appraising something as good or something as bad. And then this is sort of the process of of emotion, right? So first we have an appraisal of the situation. This lion is bad, negative appraisal. So typically then there are learned avoidance behaviors in response to that lion. So I run or I hide. However, if I have a strong emotion regulation, if I have strong emotion regulation abilities, I might be able to come up with a more logical solution for dealing with whatever that negative stimulus and my interpretation of that stimulus is. And so basically what this hypothesis says is that poor executive functioning tends to go hand in hand with poor emotion regulation. And it makes a lot of sense because, if you don't have good cognitive control, then you have difficulty inhibiting responses that are sort of automatic. You also have difficulty engaging in problem solving. And so you're more likely to respond on habitual behaviors. And you're also less likely to be able to be cognitively flexible. So when something about the environment changes, how do I adapt my strategy for dealing with something difficult in the environment such that it's solvable, or it's something that I can cope with? And so we have a study right now funded by NIMH that's looking at the interplay of executive functioning and emotion regulation in older people using functional MRI, as well as behavioral paradigms and physio and some EMA measures. And we're kind of looking at it multimodally. So more to come on the future in that area. So key point 4, so depression has been associated with cognitive decrements in multiple cognitive domains: attention, executive functioning, processing speed, fine motor function and speed, emotion perception, reward anticipation and pursuit, and memory. And people who are depressed tend to attend to and appraise stimuli more negatively. They also tend to engage in more avoidance behaviors. And then they tend to also have difficulty regulating their affect. So I want to talk a little bit before we end about some of the brain structures and circuitry that are most relevant to depression. So these are neuroanatomical regions and circuits that are of interest in depression and depressive-like diseases. So there are, a number of frontal and so prefrontal, as well as parietal and subcortical regions. So the take-home message here is that, and I think I'm preaching to the choir here, but we used to associate brain function with like a very specific structure, but and that's true still for some, very few, but some diseases. But in complex diseases like depression, it's probably more of a story about neurocircuitry and how different brain regions communicate with each other positively and or negatively. That helps to explain the cognitive and the affective symptoms, as well as some of the other symptoms that we see in depression. This is an interesting longitudinal study by a group at Columbia, where they actually imaged 131 individuals in a high risk for depression group and 65 people in a low risk for depression group. So the high risk group had a significant parental history of depression, whereas those in the low risk group had no parental history of depression. And what they found was that even before the first onset of a depressive episode in these children and adolescents, and some of whom were actually adults, cortical thinning was present in persons at increased risk. So it may be that the cortex was never as thick in these folks, and perhaps that to some degree confers risk for depression going forward. We can't necessarily make that conclusion based on these data because we don't have, baseline measurements of cortical thickness and thinning. But certainly it's interesting that these brain changes are that these brain decrements or abnormalities, I should say, are present even before first onset of depression. And here's just some additional pretty pictures. And also, interestingly, the thinning was associated with both inattention and working memory. I'll skip that. So I just wanted to say before we end a little bit more about late life depression, since that's really the area that our lab has been investigating most closely. So in late life depression, we see a lot of neurobiological differences in older people with versus without depression. So we see more gray matter atrophy in regions that are relevant for cognitive functioning. We see more white matter hyperintensities and changes in white matter microstructure using imaging sequences such as diffusion tensor imaging. We also see differences in functional connectivity during the resting state and during activation during task challenge. And then also we see higher neuroinflammation as well as reduced 5-HT1A receptor binding as revealed by PET. So a lot of different neurobiological changes that also correlate in many cases with cognitive functioning. This was a study that our group did where we looked at both younger and older people with and without depression, and they were performing a cognitive control task in the scanner. And you don't really have to be an expert in neuroimaging to see that green, which are regions that were active only in the older depressed group, but not in any of the other groups, are the most prevalent color that you see on this page. So we're seeing patterns of compensation in older people. And I should say that all 4 groups performed equivalently on this task during scanning. But the older groups had to utilize a lot more brain in order to get to that level. And it turns out that when we looked at percentage of areas within the cognitive control network that were activated, you can see that older depressed people had to activate a large swath of the cognitive control network relative to these other 3 groups, and that they activated regions that were not in the cognitive control network, which we think of as de-differentiation. So this is compensation, this is de-differentiation. You see that older healthy people also show a pattern of compensation relative to the younger groups, but the younger depressed group actually was equivalent or very similar to the younger never depressed group here. But in older adults, we start to see more functional brain changes, especially in people with depression. So key point 5, depression is associated with structure and function of multiple brain regions and pathways that are associated with both bottom up, so that would be sort of, the stimuli that come in and sort of your appraisal of the stimuli immediately, and then top down processes. What kinds of cognitive control mechanisms are you able to recruit in order to engage in successful emotion regulation? So I just wanted to end by discussing some kind of the current state to a small degree. I'm not going to review the literature completely, but of applied neuroscience and depression research. So this was a study by Diego Pizzagalli at Harvard, which looked at frontocingulate dysfunction in depression. And this was a review article looking at many different imaging studies. And it was also a meta-analysis. And so what was shown was that activation in the subgenual cingulate was predictive of treatment response following pharmacological treatment. And the effect size here was actually 0.918. So this is a similar region to what's actually being used in TMS research in depression, where this area is simulated multiple times over a course of weeks, typically. And this, this stimulation, this region for stimulation was really derived from a lot of these functional neuroimaging studies. And you can see how kind of translational research ends up turning into clinical research when you find a region that's important for improving depression. So you then target that brain region in the case of TMS research, or TMS work, I should say. TMS is now being used clinically quite a bit for depression. There have been a lot of treatment prediction studies so far using functional MRI over the years, and these bars would be higher if we extended this graph to 2021. And the hope is that these neuroimaging studies will lead us to more personalized treatments for people and a better understanding of how the brain functions in depression. And we know very likely there isn't going to be a one size fits all. So, ideally, we'll start to better understand subgroups of depression, some of whom may respond to one treatment versus another treatment, et cetera. So I just wanted to say a little bit about the study that we have that I mentioned a bit earlier. So we're attempting to better elucidate emotion regulation in older people, specifically those with depression, but we're also looking at sex differences, and we're also looking at the overall impact of executive functioning on emotion regulation. And we're doing this multimodally. So people go through a pretty comprehensive neurocognitive assessment. They also undergo tasks of emotion regulation in the lab with physiology, but also questionnaires about what they've been doing over the course of a day for a couple of weeks and what emotion regulation strategies they're engaging in. And then also we're doing remote cognitive assessment using smartphones. And so we'll be able, hopefully, to better understand how emotion regulation and cognition track with one another over the course of a day. And we think that depression probably has an effect or moderates this outcome variable, but also sex, because we know that there are differences in emotion regulation strategies that are used in older men and women, and also executive functioning. So getting a good understanding of how executive functioning relates to emotion regulation in late life may actually lead to what we're hoping is the development of more specialized treatments for emotion dysregulation across a number of different mental health conditions in late life. And then we're also, of course, looking at how the brain responds during tasks of emotion regulation and executive functioning. So currently the field is interested in understanding what treatments work for whom. So we can use neuroscience to identify predictors of treatment response and to develop more refined treatment for our patients. So I'm going to stop there. This is my contact information. I know we don't have a lot of time, so if you have follow-up questions, feel free to email me. And then I also want to thank Scott Langenecker for some of the slides that I presented today, and thank all of you for attending. And I will stop the share and take questions.
Thank you so much, Dr. Weisenbach. That was really comprehensive. We did get several questions related to your comment about cognition not improving after depressive symptoms have remitted. So I'll just read through a few of those and we'll see how many we can take. So the first one said, for the study that looked at older adults and those who have current or remitted depression but continued cognitive difficulties, was there any discussion about the length of time since they had been recovered from their depressive symptoms?
That's a good question. I'd have to look back at the article, but I believe that it was at least, a month or so. That group does very clean, very good clinical research studies. So I'm quite sure that it wasn't just very recent remission.
Sounds good. And we'll post the recording on the website as well, so people can find that citation as well. So this person said they would be interested in hearing your perspective on assessing cognitive decline in older adults in light of lifelong depression and maybe ECT treatment, for example, would you recommend maybe a lower bar for memory impairment, or kind of what would you use clinically for this patient or
Thank
hypothetical patient?
thank you for that question. That's a great question. And I've seen a number of patients just for that exact reason, where ECT was being considered, and the team really wanted to know whether this person who seemed to have a lot of cognitive difficulties in the unit actually may just have very severe depression, and was it worth going through ECT if they had a more severe form of dementia, for example. Um, so I will say though that ECT is very commonly done in people with depression and dementia. So just memory impairment or even dementia it's not a contraindication for ECT in older adults. Can you just repeat the first part of that question? Because I think I got off on a
Yeah.
tangent and I lost you.
No, that's okay. So kind of what would you recommend for identifying memory impairment for patients who may have this kind of lifelong depression or ECT treatment
Right,
path?
thank you. So one thing I didn't mention during the talk is that there is a distinction made, or should be a distinction made between those with late onset depression, so typically classified as first depression onset, like around the mid 50s or after, and early onset. So these are the folks typically who had their first depressive episode when they were an adolescent or young adult, and then have multiple episodes throughout the course of their lives. So there's been some interesting research looking at outcomes in those two groups of people, and it turns out that cognition tends to be a little bit worse in those with late onset relative to early onset depression. And but the vascular issues tend to be, there's a little bit debate about this in the literature, but they tend to be worse than controls in both groups, actually, although we often associate late life depression with more vascular issues, because the hypothesis is that some of the cerebrovascular changes in frontal subcortical regions have led to the depression onset to begin with. Our studies, I will say, so the one that I showed you with the fMRI data and some other studies that we have in the literature, all of our samples are all early onset depression. And so you can see that even in early onset depression, in the imaging studies, there's a lot of compensation going on and a lot of dedifferentiation, at least from a neural perspective. So it is important in doing your evaluation to consider whether it's early onset or late onset, but I wouldn't let it change your conclusions, because every patient is different and we never want to apply a mean to a particular patient. And then with the ECT issue, it's helpful for the treatment team to know whether the patient has a frank dementia or not. However, dementia, again, I want to highlight that it's not a contraindication, and there's actually a pretty large multi-site study of ECT and dementia going on right now, I think led by Dr. Brent Forrester at Harvard McLean.
Wonderful, thank you. And just one more quick question that we can squeeze in if you've got a minute. This person says, given the evidence that cognition does not return to baseline after remission of depressive symptoms in older adults, how might you have that conversation with patients who are actively depressed during feedback if you think that's the etiological factor for them?
Yeah, that's a great question. So it's tricky. Again, we can't apply the mean to the individual. So just because these were group differences that we saw that were quite significant, it doesn't mean that your patient isn't going to get better with effective treatment of depression. But still, I think we don't want to set up the expectation that they are going to get better with effective treatment. What we do know, though, is that their functioning is likely to get a lot better with treatment for depression. So there was a study years ago that looked at even people with dementia in different score ranges, looking at just the MMSE. And it turned out that those who were sort of moderately to mildly cognitively impaired once the depression was gone, their functioning improved drastically, even if their cognition itself did not improve. So I think really highlighting the functioning is a great motivator for people to work with their psychiatrist, their PCP, their therapist, to try to hopefully get remission completely, but at least some decrease in the amount of depressive symptoms.
Definitely. I think that's a really good point. So thank you for staying 1 minute over. I appreciate it. And thank you so much for this wonderful presentation. And we will see everyone next week. Thank you so much.
Thank you. Have a great evening, everybody.
You too.
Thanks.